both vertebral arteries is always an option. The main problem is because you don't have an objective result that you can consider in balloon test occlusion to say, okay, I can occlude both vertebral arteries without risk. It's completely different from occlude internal carotid artery, that you can perform a balloon test occlusion and be almost certain that it's safe. When you occlude both vertebral arteries, the situation is kind of, we have some doubt if we can occlude or not.
Yes. And especially in a bleeding situation, that spasm will occur, and we always avoid to occlude vessels in acute situations. It's a very tough case.
There is an intermediate situation, but instead of using flow diverters, using a Leo stent in staging 2 or 3, what do you think, Marco?
Yes, it's a possibility, trying to preserve the superior third of the basilar artery. So sometimes we can use a Leo and rebuild the proximal portion with a flow diverter. It was described by Demetrius, but in a different fashion, using an enterprise in the superior third of the basilar artery, then with another flow diverter at the proximal portion, trying to avoid or to preserve the perforators and over the ICA. It's a possibility. But in fact, I'm afraid of perforators when we have aneurysm with thrombus associated. So because this can create a problem of flow to these vessels. And when we have a basilar with a normal configuration without a thrombus association, I think that flow diverter works well if the aneurysm is a lateral wall or with another configuration. But I'm really convinced that when we have thrombus over the perforators, we have a high risk of occlusion of these vessels.
And what about the occlusion of the contralateral vertebral artery? Of course, in a non-bleed situation, do you prefer to occlude at the same time or perform a staged procedure? What do you think is more safe? Consider a non-ruptured aneurysm.
What do you think, Daniel?
I agree with Gustavo. I think nothing is good for these situations. Everything happened with me. I had 2 cases that were under aspirin only and bled as it did. When you don't do that, other thing happen. I'm not sure. It's a dilemma every time. I think the inversion of flow, it's very good when it works. When we have, the patient passes the tests that you don't have objective. For do that, it's 50%. You can that the patient will have our deficit or not. Then this to stage to occlude the vertebral artery, to use non flow diverter stents. That's things that we try, but we don't know. The results are in the results. In the group of results are bad in everything you do, and then I think that it's a very, very difficult pathology, and we don't have the answer yet for that.
Oh, thank you, Felipe. Very nice presentation. Finally, our last speaker, Dr. Gustavo Pipoca Andrade from Recife, who will present to do or not to do.
Thank you very much. It's a pleasure to be here and have the opportunity to show one tough case. and congratulations for the initiative. Well, I'm going to discuss a case of a young woman with a small asymptomatic aneurysm that had her mother and her sister subarachnoid hemorrhage, and during the treatment of her sister, she decided to perform angio MRI that showed, as we can see here, a small asymptomatic MCA aneurysm, as well as a thin A1 on the left side. Well, that's the first point that is always tough to decide when to treat those small asymptomatic aneurysms. But in this patient with the history of the relatives with subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, the decision was to treat. So we decided to put a small flow diverter stent on right MCA. As we can see here, the Revo from Acandis is a 4 by 20 millimeters in the right MCA. As we can see here, we started deploying exactly on the bifurcation of the MCA. Here is the point of the end of the stent. And when I was at the point that we cannot come back, I thought that I could bring the stent a little bit proximally to best position it. So I re-encap the stent, as we can see here, and pull back a little bit the stent and deliver it exactly on the ICA bifurcation, as we can see here, and the MCA bifurcation, as we can see here. A very, very nice deployment. Remember that she has a left A1 very thin, so I was afraid if I could cross the right A1. But here is, I guess it's perfect. The stent is exactly where I want. But what we can see here is that the proximal edge of the stent is not completely open. So I decided to put a balloon on it. The problem is that the wire of the stent is not an exchange wire. So I decided to enter through the stent with the microcatheter and change for an exchange wire. When the 027 microcatheter touched the stent, as we can see here, the proximal edge of the stent completely closed. So we can see here on detail the microcatheter tip and the proximal edge of the stent completely closed. The wire that is inside the stent is the standard wire from the stent, is not an exchange one. So what I decided to do is to keep the microcatheter there, and here starts the nightmare. To keep the microcatheter there and change for a 014 exchange wire. As we can see here, now I'm with a long wire that I can change and put a balloon. So I started with a very small balloon, the smallest one, 1.5 millimeters, as we can see here. It could open a little bit the stent. It has a severe stenosis here, but the flow gets there again because the flow was completely stopped. But after 1 minute, you should see the flow getting slower, and in a few minutes, we got completely occlusion of the right MCA again. Well, I tried with a bigger balloon, 2.5 millimeters balloon. As we can see, it opened a bit more the origin of the right MCA. The stent edge is here, and the aneurysm is here. We can see a stenosis here, a moderate stenosis, but the flow is restored, and we can breathe again. We keep waiting a little bit, and it's easy to see that each minute the flow gets slower, and in a few minutes we got again occlusion of the right MCA. Look at that, the flow is very slow here, and in less than 5 minutes, we got completely occlusion again. Here's a complete occlusion. Here I started to accept that my exchange wire was not passing inside the whole stent. Probably I passed it through edge cell of the stent, and a balloon could not open completely because the radial force of a flow diverter is very high. So I need something that has even a higher radial force to open the mesh of the stent and keep it open. So I decided to put a coronary drug-eluting stent. It's a balloon expandable stent, so it has a much higher radial force. I could navigate it until the proximal edge of the stent, as you can see here. I could not. I tried not to cross again the A1 origin, so I put the stent here. Is a 2.5 18 millimeters. Telescoping the flow diverter and opening the proximal edge of the stent. As we can see here, the mesh of the stent, the flow diverter stent crashed against the superior surface of the MCA. Now I had a completely recovery of the flow, as we can see. The aneurysm is still here, of course. There is a light or moderate stenosis of the origin of the MCA, but I guess it's acceptable after everything that we just passed. Here's we waited 3 minutes, 5 minutes, keeping doing controls to see if the flow will arrest again, but the flow was completely regular. And after 15 minutes, with a good flow, as we can see here in dynamic imaging, it's easier to see the flow. We can see that the flow is completely normal when comparing to the ACA. And I decided to keep like this with a coronary stent crashing the derivative stent, crashing the cells and opening the MCA. Here's the final result. I'm sorry, a little bit later. Here's the final results with a moderate origin of the MCA stenosis, but the stent is completely crossing the aneurysm, is keeping A1 and the middle cerebral artery open. It's very well positioned. And here you can see telescoping and a confusing mesh, confusing two stents meshing, one against the other. The patient awake, completely asymptomatic. CT control shows a small stroke here in the MCA perforator's territory, but without any clinical relevance. After 6 months, I tried to stop clopidogrel, and the patient called me on the 60th day saying that she had a left emparesia. I asked her to take 6 pills of clopidogrel and take the car and come again to our city. She lives in another city. After 2 hours, she called me saying that she was doing a U-turn because she completely recovered with the clopidogrel attack dose. 1 year control. You can see here the stents again, telescopic stents. The stenosis of the origin of MCA is lighter, is even better than before. The aneurysm is completely closed, as we can see here, with a good flow. Here we can see the work positioning of the stents, MCA and aneurysm completely closed. After 1 year, I decided to stop aspirin and keep the patient under clopidogrel for lifelong. Here is the imaging after withdrawal of the aspirin. The patient lives in another seat, but we can see that she's doing very well. And there was some tough decisions. There are a lot of points that we can discuss here, since treatment of small asymptomatic aneurysm to how to deal with those situations, or what is the best way. I thank you very much, and I'm very pleased to be here.
Yes, we're live.
Okay, we're live. So, congratulations, Gustavo Pipoca. For those who don't know, the word pipoca in Portuguese means popcorn. Okay, thank you for sharing your nightmare with us. Another case treated with the Revo, which is a flow diverter that is not available in all countries. It is widely used in Germany, Brazil, Italy, Turkey. You presented a controversial case because this is a small aneurysm ruptured, located at the right M1 segment with a branch rising from the side. So, okay, you decided to treat it using a flow diverter, and the patient was prepared with aspirin and clopidogrel. That's it. And after this stent was deployed, the patient presented a thrombotic complication due to fish mouth effect, in my opinion, that you tried to solve with a balloon angioplasty that didn't work. And finally, you decided to use a balloon-mounted stent. 6 months after the treatment, you stopped the antiplatelet. I don't remember the clopidogrel or the aspirin, one of them. And the patient presented a TAE. So I have some questions to you. But first of all, we know that there is no doubt that your complication was due to the poor expansion of the device, no doubt. So to understand what happened, it's important to review the characteristics of this device, of the Revo. So could you give us a brief review about the stent design, given emphasis about the difference between the proximal part and the distal part, because in my opinion, this is the reason of your complication. Please.
For sure, Marcos, thank you very much. The Revo stent is a braided wires that the wire starts at the proximal edge and it goes braided with other wires until the distal edge, and then it makes a U-turn and comes back. The same wire goes and come back. So the two edges of the wire are proximally, and there is no distally. All the wires are turned, are folded in the U-turns. So the distal edge is much more, how can I say, soft, and it always opens very easy. And the proximal edge that is cut by laser, and where are all the wires edges, it's the problem. I would say that is the Achilles heel of the Revo stent. So the design of the stent, we are always insecure if the proximal edge will be widely open. That's the point of this device, in my opinion.
Okay. And two questions. First, could you explain us, I know the reasons because you show in our first slide, but could you repeat why you decided to treat these aneurysms, because we have these questions at our audience.
Yeah, that's a good point, because this patient, her mother had died from subarachnoid hemorrhage 15 years ago, and her sister had a subarachnoid hemorrhage, and and came to our hospital to treat. And during the treatment of her sister, she decided to do an angio MRI. So they were very sensitive, and well, if I had my mother and my sister with aneurysmatic subarachnoid hemorrhage, and I find an aneurysm in myself, I would treat also. So it was a multidisciplinary discussion, and with the patient and her husband, and everybody together decided to treat. So that was the point. She's had a very, very huge history of subarachnoid hemorrhage in her family.
And do you think that if you had used a self-expanding stent like Neuroform, for instance, it would be able to expand the fish mouth? And why did you prefer a drug-eluting stent? Why not a conventional? Could you explain your preference for the balloon expandable stent?
Yes. In the beginning, I thought that it was just, as you say, a fish mouth. But what I realized then is that I probably did not cross the stent with the exchange wire through the whole stent. Probably I entered in the derivative one, the distal cells, the mesh of the stent are open, are not flow diverted. So I probably passed the wire through a distal cell, and then I was putting balloons. The balloon can open a little bit the stent, but with time, the stent goes and closes again. So I really don't think that a Neuroform or any other auto-expandable neuro stent has more radial force than a derivative or any other flow diverter. I really think we need a balloon expandable stent that has the much more radial force. Well, a drug-eluting or a bare stent, I think both of them will solve the problem. I choose the one that I had available during the procedure. There was two meshes of the flow diverter that I was crashing through the middle cerebral artery. So I think that it's a lot of mesh from two meshes of the stent, and the third stent that I'm putting, the third layer of the stent that I'm putting. So I think I can induce a lot of hyperplasia. So I really think that a drug-eluting would be the best solution. But I completely agree, if you use a bare stent, you're going to solve the problem as well. And we'll have less problem due to double anti-aggregation. Of course, the drug-eluting stent is much more thrombotic than the bare stent.
Gustavo, very fast, because we are finishing. Why not the snare? Very fast.
Why not? Sorry, why not what?
Snare the stent.
Oh. Yeah, I tried. I thought about, but I really then when I passed the exchange wire, I didn't think that I was through the distal cell. So I keep trying to open the stent, thinking about a fish mouth. But if I realized since the beginning, I completely agree with you. I should have withdraw everything.
Well, Marco, I think you can close your session.
Yeah, so it's okay. Thank you so much, everybody. Let's continue with another session. Bye-bye.
Thank you to the Brazilian
Thank
time.
you very much. Very nice
Let's
session.
Right, thank you.
To Chile right now. Thank you, guys.
Good afternoon, everybody. I am Rodrigo Rivera from Santiago de Chile. It's 12 o'clock in the afternoon here in Chile. Thanks, Mario Galdames, for the invitation, and congratulations for the organization of this unique 24-hour format meeting. So welcome, everybody. Today we are going to talk. We're going to have the talk of three colleagues from Chile. We're going to start with Dr. Juan Pablo Cruz from Santiago, from the Instituto de Neurocirugía, and then we're going to continue with Pablo Jackeman from the Regional Hospital of Concepcion, and finally, Dr. Marcelo Baldosa from the Regional Hospital of Temuco in the south of Chile.
Hello, everyone. Good evening, good afternoon, good night, depending on where you are. My name is Juan Pablo Cruz. I'm presenting on behalf of Juan Gabriel Sordo from the Instituto de Neurocirugía in Santiago, Chile, a case of a coil migration in a ruptured PCOM aneurysm. So this is our patient, a 74-year-old male with chronic hypertension, started with headache and consciousness, decreased level of consciousness, initially with a Glasgow Coma Scale of 6. After aggressive neuroresuscitation, the Glasgow Coma Scale raised to 11, and he arrived at our center at GCS 15 with no focal deficits. The CT showed fissure 3-4 subarachnoid hemorrhage, thick hemorrhage in the basal cisterns, and intraventricular clot with an aneurysmal pattern. Nothing really clear, something suspicious on the PCOM on the CTA, so he went to an angiogram, and the angiogram showed a small PCOM aneurysm in a fetal PCA, a broad neck, small ruptured PCOM aneurysm, where relatively straight access, but not from the bifurcation properly, but it seemed more like from the fetal PCA itself. So now, what are our treatment options in this case? We can use a balloon remodeling technique. The issue with the balloon remodeling technique is even with a hyper-compliant balloon, it would be hard to herniate the balloon enough to protect the neck of the aneurysm, and in doing so, we could push the tip of the catheter out of the aneurysm as it would go down into the fetal PCA. We could go with just straight, simple coiling, with a stent-assisted coiling, but it would be hard to flare even an open cell stent to protect the neck of the aneurysm. And surgery is clearly an option, but in this case, the surgical risk of the patient because of his age and comorbidities was deemed to be high by the neurosurgeons. So a decision was made to go primarily with endovascular therapy. Our initial intention was going with simple coiling using a 7 French axis, just in case we would need any extra devices, just to have enough lumen to go up with whatever extra device we needed. 45 Echelon 10 and Transcend X. Target 360 nano coil was chosen, which was delivered into the aneurysm carefully just by playing with the tip with a little bit of forward pressure and releasing the pressure, so we'll be able to build the proper cage. You can see as this coil is deployed in the aneurysm, it conforms adequately to the shape of the aneurysm with no suspicious movement of the coil during the deployment. We're pretty happy with the result, and it looked pretty good. So we detached the coil, and we usually, to retrieve the microcatheter, we play with the pusher, a little bit of forward pressure. So for the pusher to actually push the tip of the catheter out, we can see now as we're detaching the coil, seeing if it's detached, playing with the pusher with a little bit of forward motion, and we're able to actually bring the tip, and as the microcatheter comes out, the coil migrates into a distal MCA, a frontoparietal branch M2 bifurcation, distal M2 into a bifurcation of frontal and parietal branch. So now this is our scenario. We were pretty okay with our coil in the small aneurysm, and now we have a distal migration of the coil. So what do we do? The coil is in a distal branch. We could use a snare or an alligator, but usually it's a pretty rigid system and goes to relatively large microcatheters. And to go with one of those into a distal branch didn't seem to be such a great idea. So we decided, this is the scenario here. This is the route to our migrated coil. This is the size of the vessel. And it looks pretty hard to get a relatively rigid device, coil retrieval device as the snare or the alligator up to here. So what we did was we decided to go with a gamma 17 over the same transient X to cross the coil mass. We can see now the tip of the microcatheter navigating through this parietal branch of the MCA. Here we were able to go through the coil mass. It moves as we are pushing through it. Some of the loops just straighten up. You see as how the artery straightens up too as we're navigating with the microcatheter. Initially, if you look only at the roadmap, you would think that we were out of the vessel, but it's just the vessel is a misregistration artifact due to as the vessel moved. Now we go up with a Catch Mini, a small stent retriever that allows us to use a smaller microcatheter, and it's designed to go into distal thrombectomies. So it does deploy pretty well on smaller branches. We open the Catch Mini, and then with the Catch Mini deployed, we bring it back open. See as there's the distal tip marker. See as the coil entangles with the stent struts and comes back pretty much tangled in the stent. So a successful coil retrieval. The only issue is that after a lot of effort, we were pretty much on the exact same place we were at the beginning of the procedure. So we were starting basically all over again. The small aneurysm, and we needed to treat it. So this time we decided to basically use the Catch Mini as a transient scaffold. We deployed and opened the Catch Mini as a stent remodeling technique, but with the intention not to leave the stent over there, as it's a non-detachable stent, and any detachable stent would require dual antiplatelet therapy, which does not seem to. If you can avoid it during the acute phase, it's preferable. So we use it as a scaffold to keep the tip of the catheter in the aneurysm and secure the coil as we retrieve the aneurysm after coil deployment. So after this, we delivered the same the new 1x2 nano into the aneurysm. Again, it conformed pretty well. Less capability of moving or playing with the tip of the microcatheter because of the open stent, but it conformed pretty well to the shape of the aneurysm. And we retrieved the microcatheter with the stent open just to avoid microcatheter retrieval migration, as we saw in the first case, and the coil stayed there. This is a CT angiogram, which is such a little coil, such a small coil that doesn't even generate a beam hardening artifact on the CTA. And the patient had a good clinical evolution, good clinical outcome. He had no major complications during the recovery phase of the subarachnoid hemorrhage, no delayed cerebral ischemia, no vasospasm. And he was discharged neurologically intact. And on his 3 months control, he showed to be independent on a ranking scale 0. So these are some of the references of stent retrievers used for distal coil migration that allow you to get a more distal access of the vessel. And I want to thank you all for your attention, and I hope you enjoyed the case.
Thank you, Juan Pablo. That was a very interesting way of getting out of that really nightmare of getting a coil that migrates so distally in such a small vessel. It was a very, very difficult anatomy of that tiny aneurysm. It's not the neck to fundus radio was low, so it was really difficult. Looking at retrospectively, what do you have done different in the first stage? You used a balloon, or use the same stent that you use in the second phase?
So yeah, in retrospect, we could have used a balloon more with the intention of protecting rather than remodeling the neck. Actually, just hoping for the coil to stay in place, because as you run the angiogram, you can see that the coil migrates not at the moment of the detachment, but and the actual microcatheter comes back and does not move the coil. But I'm not sure if we created some sort of vacuum effect or Venturi effect as we retrieve the microcatheter, because it migrates when the tip of the microcatheter is around 2 centimeters from the neck. So maybe that would have precluded the coil for migrating in the first occasion, but for the purpose of neck remodeling, I don't think a balloon in the ICA would have been that successful, because especially wouldn't have allowed us to play that much with the tip on the forward pressure of the microcatheter that allowed the coil to oppose properly to the side walls of the aneurysm, and in the final case, it just keeps it in place. Another option would have been to try to put the balloon into the PCA to get a better protection of the aneurysm neck, but you would be overinflating. Even though it's a hypercompliant balloon, you will still be overinflating a balloon in a relatively small vessel for the balloon size. So that could be kind of an issue.
Do you think, Juan Pablo, that this type of coils that is very, the construction of the nano is an excellent coil. It's super soft. Do you think that softness play a role here in the final staying inside the aneurysm? Maybe a little more stiffer coil would stay in the first place?
I'm not so. I think that the idea of choosing a nano was that it's actually because of the size and being such a small aneurysm, the risk of that first loop actually perforating the aneurysm or pushing the microcatheter out was considered like highly likely then. So we went with the softest coil available. And the actual construction of the nano, I think, allows the operator to play a bit more with the coil and not create this sphere rather than an oval. So you would be getting some more of pressure on the upper and lower wall of the aneurysm that actually may help you keep you in place, which worked on the second part of the procedure. We were much more careful in retrieving slowly the microcatheter with the stent there, so to avoid any sort of sudden motion. But I think it's actually the softness of the nano that allowed us in this particular case to keep such a small coil inside an unfavorable aneurysm.
Mario, would you like to make something for the audience?
Yes, there's one question is, do you feel there is any difference in terms of retrieval between, the different stent retrievers? Is it specific, do you prefer embotrap over solitaire retrieval or, other type of stent retriever for retrieval?
So what made us choose in this case, a Catch Mini was the size of the microcatheter that it goes through, and the size of the stent itself. It's a softer stent. It's a shorter stent. Any 18 microcatheter would have been much more rougher on a small branch. So we thought of it as a distal thrombectomy. From the construction of the stents themselves, I don't think we know if there's any better chance of actually tangling the coils within the stent struts. If it's like the Solitaire, which is flared and opens up, or the Cribo or the other ones. Embotrap I haven't used, so I couldn't comment on that particular brand. But the reason here was basically the softness of the microcatheter and the softness of the stent. We have been able to use small stents in our institution because of buying processes. We have the Catch Mini, nothing in particular with that stent, is the one that we have available. And we've been able to navigate distally into small branches, so we know we can do it and it's less traumatic. Even though it creates a lot of anatomic distortion, as we saw on the roadmap, it's not that traumatic on the vessel. There was a little bit of spasm, which is what we usually see on more distal thrombectomy or on the middle vessel occlusion. But just because of that, I don't think the construction of the stent itself would make much of a difference.
You know, we did a very basic analysis, and we did it in vitro, and we compared, and we saw that by comparing the regular tubular stent retrievers, you compare with other more complex, like for example the ERIC, which is a multi-cage, or other ones. Mm-hmm. So the more complex design, the more chances to trap the coil. Mm-hmm. more than the tubular. Indeed, we did this in vitro testing, and this public a case report based on that. But I think that we need more tools in order to get these coils out. There's one question more for the audience. I'm going to show you right now. Tell me when you see it.
Should we wait for 1 or 2 minutes before detaching such a small coil and removing the microcatheter? The microcatheter immediately after coil deployment. I think it's reasonable. You're changing the temperature of the metal that you're. I'm not sure how that will change the physical properties of the coil. It would expand the minimal amount, so create more pressure over there. But it sounds reasonable. In the second time we did it, we were much more careful, but we had another confounding factors like the stent in place and the speed as the microcatheter was retrieved. So, but it sounds reasonable just to let the coil sit in and accommodate.
Okay, there's no more
Thank you, Juan Pablo.
Do you want to continue?
I think we can go to case number 2 from Concepcion City. Paulo Jackaman, please.
Hi, my name is Paulo Jackaman. I'm a neuroradiologist in Regional Hospital at Concepcion, Chile. And we show a case of tandem occlusion in a patient, previously healthy 40 years old man. Day prior to admissions and referred headache. And at the hospital, he have a history that began at 12 and 30 with dysarthria and left hemiparalysis. Then NIH was 15. At 40 hours p.m. It's performed an angio CT and TC, and that shows that aspect 9, as you can see the slides, have a compromise of the lenticular compromise in right side, and this correlates with occlusion of MCA M1 segment So posteriorly is go to angio suite room. As you see in the angiosity, we can see a lot of clots in carotid internal artery, and also the occlusion in MC1, MCA, sorry, as we see with Brainomics. That is a tool we have at the hospital to evaluate this stroke case. We can have information about the occlusion of the vessel, also aspect, scale, and mismatch with perfusion CT. In this case, we have a huge zone in penumbra zone and practically no core or no infarct installed. The information that we have with the software says that have about 100 milliliters of volume of brain that is in penumbra zone. In this case, we use femoral introductor, ex-French, and local anesthesia. We use a guiding catheter, Neuromax, and perform an angiography when we can see complete occlusion of the carotid internal artery. Posterior continuous aspiration by Neuromax use a Vecta 71 rebar microcatheter and microwire transient to get a M2 segment, the MCA. Use a Solitaire stent retriever 6x40. Posterior, I retrieve the Vecta and the Solitaire when combining techniques, getting a low amount of clot in the stent. This image shows the partial recanalization of the carotid with a huge dilatation of the proximal part and defect in proximal next to the catheter segment, very irregular in the posterior wall. So posterior, as you see, you can see a defect in this proximal part of the carotid. And at the next run, again, I see occlusion of the carotid internal artery. So I decide to use a macro guide wire command and balloon track to predilate the defect in the carotid. Also with continuous aspiration by Neuromax. After this, the aspiration and the use of the balloon angioplasty, and again to get to M2 M1 ACM artery, there was a partial recanalization of the carotid internal artery about the ophthalmic segment. So again, new reocclusion of the internal carotid artery. So I leave the micro guide wire command at the level, the distal part of the carotid dilatation that we cannot see now, with intention to use stem, carotid stem. So I repeat again the same step of continuous aspiration in Neuromax and use before the stent implantation Agrastat that we use in bolus in 3 minutes, and posteriorly I deployed the stent double layer Casper 8x40. At the new control angiography, see a again, a reocclusion of the internal carotid artery and the external carotid artery too. So it was a situation very complex because I don't have really clear what to do. So I put the catheter, the NeuroMax, inside the stent. I perform a road mapping and try to recanalize the internal carotid artery with a super stiff wire and Vecta 71. That was possible, and posteriorly I put with a rebar microcatheter transient soft tip solitaire 6x40 again in M2 M1 and using combined technique. So posteriorly, as you see in the image, we can see a total recanalization of the MCA artery and the carotid artery with occlusion of the external carotid artery. At this time, we use Plavix orally, 600 milligrams, and we use an angiosuit to close the femoral approach. The expert CT control at the angiosuit show a little defect. It was what artifact of the patient has a little movement, few movement. We can see a defect in the lenticular, the right lenticular nucleus. The control at 6 hours with CT shows a defect in the same place, but the rest of the brain was without another lesion. The patient was fine, the NIH down to 2 points, but you can see in the angio CT at 6 hours a reocclusion of the carotid stem, but with a communicating artery that fills the right size that is without clot. Patient was discharged 5 days of the hospital without neurological deficit. That's it. Thank you very much.
Thank you, Pablo. That was really an amazing case. When you have to face those type of cases, that's really a nightmare. So great for the patient. I think you one of the greatest things you did for the patient to save a lot of brain was to go to head first. That is still controversy if to start in the neck first, when facing tandem lesions, to go if go on the neck or in the brain first. There's still a controversy of that. So you started with the brain, and probably that for sure that saves a lot of brain for the parenchyma and the life of the patient. So looking into this case, what do you think was the underlying cause of the internal carotid disease?
I think that it was a dissection, probably. This kind of dilatation of the carotid artery, finally we saw when I put the stent. For me, it's very uncommon. The possibility, I think, that it was a dissection, occlusive dissection, and that I think that was the situation in this case.
It looked like a dissection, and what do you have an explanation of what happened with this restenosis after the stenting? Because before probably is the not the opening of the dissection, but after you put a stent, is it could be something in the distal part of the stent?
Yes.
Still.
Yes, I think that in the distal part of the stent it was I don't know if it's a continuation of the dissection or it's a new dissection. I don't know, but probably I could put another stent, a little stent at this side, at this part of the section, and probably not reocclude it again.
Mario, do you have an experience in using, for example, flow diverters in cervical dissections?
That's a good point. I was just going to mention that when you have a dissection, because very distal, entering into the petrol segment, so we don't have any specific stent yet into the market. So we combine a lot the flow diverter distally, and then proximally we put a carotid stent. I don't know if you have the same experience, because at the end, the distal ICI is the most controversial part to reconstruct.
Well, it's always difficult to make the turn with a very stiff with the cervical stent. It's almost impossible to go up in the petrous segment. So yeah, we don't use too many flow diverters for this section. We try to use some cardiological stents. Maybe it's cheaper in our South American reality, and then we go down with a cervical wall stent, or in this case a Casper. Do you have any concern, Pablo, with using a double layer stent in carotid, an acute phase stroke dissection or stenosis in tandem lesions?
Yes, usually we have a good result with this kind of stent in acute phase or elective patient for carotid stenting. But yes, I think that it probably have more possibility of making any stent thrombosis. That is something that is we know that could happen with this kind of stent, but it was I had in the angio suite in that moment too, so I don't have another option for this case particularly.
We have one question from the audience. I don't know, guys, if you want to answer, from Victor Jackson. So no touch, like an option. Yes. What do you think?
I don't know. Yes, probably it wasn't a chronic dissection and occlude completely. I don't know, but in the in acute phase, we try to do the best. I think that's a good option to try to open the carotid artery and to save the artery. But yes, it's probably it was another option to open MCA and don't touch the carotid. It's a possibility.
I think one interesting thing, guys, also in technically, and I would like to know your opinion, guys, is if you prefer to use a filter distally to work on it, or just work with a proximal balloon guide catheter and with flow reversal. Do you have any preference in general terms in a stroke for tandem lesions like that?
I prefer the second one.
You, Rodrigo?
I don't use a filter. I always try to go cervical first and then up, the opposite way that I showed today. But I think the option of the balloon occlusion, the knife French cello or the other of the brands that allows to use a stent inside the guiding catheter, it's a very good option, because you have the blockage of the anterograde flow. So I think it's a very good option to use a balloon catheter and then go up and open the carotid or do it or the brain first.